So my name is Cassandra Agenor, and I am the medical director of Brooklyn SART and one of the ED attendings for some of you who don't know me. Ms. Blair, who's our Brooklyn SART coordinator, will be coming in shortly to talk about the forensic exam component of SART in general, and hopefully Ms. Budd, one of our forensic examiners, will be able to join us as well. If at any point while I'm talking you have any questions, feel free to stop me and just ask it at any point. So what we'll be talking about today, we'll just start off by defining what sexual assault is. We'll talk about the sexual assault response team and the medical management of patients who come in with sexual assault. And then we'll go on to talk about the evidence collection kit. And then we'll break out into small sessions just so we can sort of like look at the kits more closely. And then you'll have an opportunity to ask me any questions or ask our forensic examiners questions. So some of you may have seen this lecture already. And if you did and you have questions, please ask me. I think a lot of things, the feedback that I've been hearing is that a lot of residents who did get this as interns, they felt like they had more questions once they started seeing these patients in real time in the ED. Obviously, we're available at any point. If you do have questions in real time, you should always activate SART, but you can also call me as well. So what is sexual assault? Sexual assault is an act of violence where sex is used as a weapon. So it's different than any other form of violence where the individual, the victim's body is actually used as the actual weapon. So in general, we define it as any form of sexual behavior that is not consented to and that causes discomfort, fear, or intimidation. And this can include anything from indecent exposure to unwanted physical contact, including oral, anal sex, and vaginal rape as well. And sometimes it doesn't include actual penetration with someone else's body organs, but it could even be an instrument that's used. Just in general, any sexual contact without consent is a crime. And when we're talking about sexual assault specifically, there's a lot of social barriers that we have to consider that our patients are experiencing before walking to the ED and stating that they've been sexually assaulted. You have to think about the fact that rape is the only crime where the individual has to explain that they did not want to be raped. So if somebody's walking down the street and they have a nice watch on and they happen to get robbed, they don't have to say, oh, well, I didn't want to get robbed. I didn't want someone to take this watch away. To take my watch, So in general, this is something that a lot of victims have to experience, unfortunately. The victim always feels like they're on trial. And the rape is treated very differently than other felonies. And not to mention, there's a lot of embarrassment, shame, and fear of retaliation. Who will believe me? And did I bring it upon myself in some shape or form? But in general, just keep in mind that sexual assault is never the victim's fault. It's always the responsibility of the person who commits the act of sexual violence. And why is this relevant? Because it directly impacts the community that we're treating. One of our residents just told me just now how many cases that she's been seeing, more cases of sexual assault than she's seen in the previous years. The thing is that when we learn about new things and we're actually looking for it, we actually start seeing it. But these cases have been around for a very long time. When we look at the number of people who are victimized each year, there's about 80,000 inmates, 60,000 children, almost 500,000 general public, and 19,000 in the military. So altogether, like about every 68 seconds, there's an individual who's being sexually assaulted. Of these individuals who are being sexually assaulted, about 1 out of every 6 identifies as a woman when it comes to attempted or completed rape. For the majority of sexual assaults, they tend to occur in victims who are under 30, but that does not mean to say that an individual who may be in their 60s or even above might not be sexually assaulted. Because you also have to think about in the context or where they're being sexually assaulted. If you have individuals who have dementia, who are in nursing homes, if they are being sexually assaulted, do they have the ability to report their sexual assault, especially if the person who's caring for them is the one who's assaulting them? So don't be surprised if some of those numbers are low, especially if you see here with the age 65 plus. Same here. Now, 9 out of every 10 victims of rape is female, which means about 10% identifies are basically males. But the thing that you have to think about in general with this number is that this is an underreported number. Like you mentioned this earlier, there's a lot of stigma that comes with intimate partner violence. The same thing goes with sexual abuse and sexual assault and rape. So it's not surprising that it says only 1 out of 10 are actually males, but I wouldn't be surprised that number is higher. Especially when it comes to our LGBTQI community in general, the numbers are significantly higher. And sometimes they're not represented here. When it comes to male college students, they tend to be at higher risk as well. Lighty mentioned this as well before in her presentation. The thing is that we tend to think in general, when it comes to sexual assault, tend to think it happens like in Law and Order SVU, where someone's walking down a dark alley after a night that out partying, and that's how they were sexually assaulted. But actually, in most cases, most sexually assaults that occur happen by someone who's known to the victim. And if you look at the numbers here, 55% actually happen at or near the victim's home. And unfortunately, out of every 1,000 sexual assaults, 975 perpetrators will walk free. Which is why the sexual assault response team is extremely important. There are so many things that needs to go right in order for these individuals to or for the victims to actually seek justice and achieve justice. So what is the sexual assault response team? It's a multidisciplinary approach. It includes with the victim as being the center of, or the survivor at the center. And then we have different individuals who are extremely important in the success of the sexual assault response team. One of them includes the social worker, the advocate. The other one is the forensic examiner, special victims detectives, the prosecutor, and the judicial system altogether, and of course, the medical provider. So when we think about the multidisciplinary approach, first, the medical component, which consists of most of us in this room here, is a direct treatment of any sort of injuries that the individual may have as a result of the sexual assault, or in addition to that, providing medical medications and prophylactic medications, and also testing for STI and HIV. The forensic component includes a forensic interview and also evidence collection and photography. And then you have the psychosocial component, which is offered by social workers here at Kings County. Then we have the law enforcement, and they're responsible for most of the investigation, the interviews, and actually investigating at the actual crime scene. And then we have the prosecutors who will often get expert witnesses, including our forensic examiners, to testify, to explain exactly what a sexual assault is and why sometimes there's actually no physical injuries on exam. So why is the sexual assault response team so critical? Well, rape in general is physically and psychologically traumatic. And unfortunately, if we're not aware of this when it comes to our patients, we may unintentionally extend that trauma. Or if we are aware of that, we can also be a part of the healing process and initiate that in the ED. So it's extremely important that the sexual assault response team is involved, or not involved, but in general, the sexual assault response team is active and activated because it's instrumental when it comes to the successful prosecution of sexual assaults. And why is that such a big issue? Because in general, the victim is often the only witness available to or that was present to state exactly what happened to them. So it can make it very difficult for the prosecution of the actual sexual assault. And there's a high standard of medical care is needed in order for the victims to actually experience recovery. And a lot of times that starts with just having the social worker come in and seeing the patient and being able to provide them with resources as well. So in our ED, we have a SART operator, not hotline, and they're available 24/7. So whenever a patient comes in and they state that, that there's been a sexual assault, typically the triage nurse will activate SART. The operator at that time will ask for basic information, including the name and the time of activation. And then at that point, the forensic examiner will typically present to the ED within 1 hour of SART activation and the patient being medically cleared. And we will talk about that a little bit more later. So when it comes to the sexual assault forensic examiner, these can be nurses, nurse practitioners, physicians, physician associates as well. And they are specifically trained in communication skills, on forensic history taking, physical assessments, doing detailed evidence collection, and also photo documentation, and also and trained in how the criminal justice system works as well. And this is extremely important because it provides focus and competent, compassionate care for our patients. In addition, that also helps improve the quality of forensic evidence collection. So this is where we all come in. So when a patient comes into the ED, every patient who comes into the ED should be given the New York State Sexual Assault Victim Bill of Rights. This is available on SharePoint or also on Clinical Monster as well. It basically states that the patient has the right to receive care in our hospital, regardless of their race, their national origin, religion, sexual orientation, disability, and so forth, including their immigration status, and especially when it comes to minors. Minors who are under the age of 17 can still receive care when it comes to sexual assault without their parents being notified, which is a little bit different than what you typically see in the pediatric ER. For most cases, or all cases besides sexual health, we have to get in touch with a guardian or a parent. But in the case of sexual assault, that is not the case, and they can receive care without their parents being notified. It also states that the patient has a right to an advocate, and our advocate in our hospital is currently the social worker, which is why every patient who comes in through the ED, usually, if not already informed by the triage nurse, the social worker should be consulted by us. And we have to put in an order as soon as the patient presents to the ED. We inform them they have the right to an examination, not only for medical care, but also for evidence collection. And we also provide them medical prophylactic medications when it comes to STIs and HIV as well, including testing. The patients have a right to report to the police and a right to not report to police. And we do inform them of that right if they choose to use it. This is the second form. So in addition to the New York State Sexual Assault Victims Bill of Rights, this is the second form that's also available on SharePoint and also on Clinical Monster that you should give every single sexual assault patient that comes to the ED. A lot of times when SART is activated and the forensic examiner comes in, they will provide the form to the patient as well. But in general, we should always give it to a patient, explain to them that under the Office of Victim Services, all the expenses from their medical care will be covered. But they just have to indicate that they want the Office of Victim Services to cover those costs, which means that this will not be billed to their insurance and they will not get a bill that they will be required to pay after their visit. So those two things, in addition to activating SART, should be giving the patients the New York State Sexual Assault Victims Bill of Rights and the FRE form. As I mentioned before, our social workers are our advocates for our patients here. So you definitely want the patients to see the social worker, and they should not be discharged without seeing the social worker. So now when it comes to activation of SART, let's say this was mentioned earlier today, where someone said, what if, for example, a patient came in with sexual assault, but they came with other complaints and they did not mention it during triage, so SART was not activated. And now while you're talking to the patient mentioned that they were sexually assaulted. So before activating SART, you want to make sure the patient is medically cleared. So in addition to our regular ABCs, when it comes to airway, breathing, circulation, everything else, and making sure the patient is stable, some additional ABCs when it comes to SART, before SART activation should be, is the patient alert? So if a patient has been medicated, for example, like they've been given Haldol, Ativan, Versed, and they're not alert, then at this point, you can call SART to provide additional information, let them know that there is a case. But at this point, the patient cannot be in a state of mind where they would be cooperative and be able to consent to forensic examination. So that's extremely important to know, because when it comes to medical evaluation, we can treat patients, evaluate patients, especially when we're concerned for life-threatening injuries, without getting consent. But when it comes to forensic examination, that is different from medical examination. The patient has to be alert, cooperative, and be able to consent specifically to forensic examination. Okay.
It's like concerned for like elder abuse and maybe the patient has like dementia. Then where does that fallen. And so then then you cannot do a SART kit. Is that how that would work?
Well, I would say you still activate SART, the SART team, because there's specific things that we can use when it comes to determine whether or not somebody has capacity, right? And whether they can give consent. So it's the same thing when it comes to somebody who has a disability, like a 16-year-old who may have autism, for example. It may involve different questioning and different in order to determine whether the patient has capacity in order to give consent or assent to a forensic exam, if that makes sense. But in that case, it would be like a guardian or a parent who'd be able to give consent, but the patient would have to give assent where they're able to say they're agreeable to doing the forensic exam, if that makes sense. So I would say still activate SART and it still requires a discussion.
How about for like intoxication or decompensated psych disorder?
That's a very good question. Very good question. So when it comes to deterioration of any form of chronic illness, for example, whether it be asthma, COPD, somebody who has CHF or AFib, these patients need to be stabilized before a SART team can come in and do a forensic exam, because the forensic exam does not occur in the ED. It happens in the crisis center. So there are no monitors there, so the patient has to be stable. So in the same way that I mentioned those sort of chronic illnesses, the same thing when it comes to psychiatric illness. So a patient who has psychiatric illness, like say schizophrenia, they can still get a forensic examination done. And unfortunately, a lot of times patients with histories of mental illness, they're actually at high risk of sexual assault. So you have to keep that in mind. But if there's deterioration of the psychiatric illness, so let's say the patient is acutely psychotic, they're responding to internal stimuli, they're having tangential speech, and things like that, then the patient in that case is not medically cleared. And in any other case, you typically call psych to see that patient. So you still have psych come see the patient. And even if psych states that the patient has, let's say, capacity or, in general, that patient's not safe to go to the crisis center to experience a forensic exam. And Ms. Blair will talk more about the forensic exam, but in general, it's not an easy exam to experience yourself. We have great forensic examiners who are trained in being very sensitive to the patients, but you don't want a patient who's acutely psychotic going through a forensic exam. Okay. And if there's ever an issue where psych says the patient has capacity or anything like that, you can always escalate the case. The safe examiner knows to contact Ms. Blair if there's any issues. And also myself, I can also get involved, especially if CPEP is rejecting to take the patient. Because just to let you know, if the patient goes to CPEP because they have a deterioration of their psychiatric illness, they can still get the forensic exam. The forensic exam can still be done, but the patient has to be more stable. So sometimes there could be a little bit back and forth when it comes to that, but we can have a discussion.
Experience they say they want to like do it in there and they get on patients like stable.
Exactly. You said they've accepted them to see.
Yeah, yes.
Great.
The psych doctor come and say, hey, we're gonna like take the patient there, we're going to then make them a little bit more stable, and then the kid can be good.
Exactly. So I don't want you to think that because the patient goes to CPEP that the kit will not be completed. We have 120 hours, which is about 5 days from the time of the sexual assault, to collect evidence. So when it comes to history taking, in general, unless the patient, let's say they're coming through CTT or there's concerns where there are injuries that you feel like you have to medically manage at that moment in time, for the most part, the patient should remain fully dressed, because there's different forms of evidence that we can potentially lose if we have the patient on gown in the ED. So we don't recommend having the patient undressed and getting into a gown unless there's a reason for it that's medically indicated. When you talk to the patient in general, you want to be at the eye level. You don't want to interrupt them, and you want to have a very non-judgmental tone when you're talking to them. And you want to be able to validate their feelings, just to help them be able to regain a sense of control, especially after having such a traumatic experience. And of course, you want to listen to them. When we're activating SART, as I mentioned earlier, if SART's coming in to see the patient, you don't want to ask or do a forensic interview. The sexual assault forensic examiner once they get the patient to the crisis center, they will ask all those detailed questions and they will document it in the forensic chart, which is not part of Epic. Okay, so basically when you see the patient and SART has been activated, you only want to document what's medically relevant. And just in case you are seeing a patient and something just doesn't make sense, there's a lot of holes in the story, there's lots of gaps. They say they were in one place or another place at another time, but there's gaps in their story. You have to consider drug or alcohol facility sexual assaults. With these kind of patients, they may mention they have loss of consciousness, inability to resist, or memory loss, and also vomiting as well. So just keep that in mind. If the story doesn't make sense, that it might be a drug or alcohol facility sexual assault. So now when it comes to our physical exam. So when it comes to our physical exam, we have to keep in mind that up to 45% of patients who are sexually assaulted have actually, they'll have actual physical injuries that are non-genital. So at times it could be a patient who comes in after a strangulation that we mentioned before, or it could be a stabbing or a gunshot wound. All of these things can happen during a sexual assault. I'm sure you guys know how to manage that, or, or have certain steps that you take when you're in CCT. But in the case of these patients are in the main, you might discover they may have a stab wound that wasn't identified during triage. So just make sure that you document any form of injury, physical injuries, when it comes to non-genital injuries, in the medical chart. And when it comes to documentation of injuries in general, most of the time you'll see a lot of blunt force injuries, which is like abrasions, contusions, and lacerations. I'll define that a little bit more later, but in general, when you see any form of injury, you want to, tears is a good mnemonic in general, so you want to document any tears, like ecchymosis, like redness under the skin, abrasions, like scrapes, or erythema, or swelling. In addition to that, you want to document the location. Where is it located? What does it look like? Just describe the color, the shape, the type. Is it abrasion, contusion, the laceration? Is the patient tender when you touch that specific area? Or do they say that when you touch that specific area that it elicits pain? And you want to document the size as well. So these are different terminology when it comes to blunt force injuries that you might see on examination. You may see abrasions, like I mentioned, which is like almost like a scrape, contusions, which is like bruising underneath the skin, lacerations. Just keep in mind when you're documenting, if it's a stab wound, it's not a laceration. Laceration is a form of blunt force injury. So usually you'll see edges that are sort of like ragged, that are discontinuous, and those are lacerations. But if it's a stab wound, then you just describe it as a stab wound, but don't use the word laceration. And then there's avulsions and fractures as well. Okay, and we never want to date contusions. Go ahead, Ms.
Correct to the documentation. If it's a SART patient,
You don't.
there should be no double documentation. in the
Right.
medical record. Think that, because if you're documenting and it's contrary to what we're documenting, everyone will be called to court. So usually documentation from the patients that we are attending to are referred and it's literally written, deferred to documentation done by SART exam. Because they are reporting back to the team as to any major findings that are found within the assessment that can be seen by the offending or the resident at that time. So don't double document what you're seeing, because it would be contrary to what is written. We're taking pictures, we're documenting, and any deviation, it's going to be warranted a subpoena from the DA's office.
Exactly.
So that includes like physical exam findings such as cuts and stuff like that?
Correct,
Or is it-
because that's why with our patients, the crime scene is the patient, so usually an assessment, when I get up, I'll explain an assessment is basically a stable patient walking in the room and saying, I am Dr. Jones, do you have any complaints that I'm not seeing right now? So that meaning if they were strangulated, if they have severe abdominal pain, something that needs to be addressed. Other than that, everything is referred to the team being involved. There's a twofold. Kings County now started their strangulation protocols. So with that, the protocols has to be followed. Coming in, assessment has to be done by the EP down physicians and documented, showing whether it warrants a strangulation pathway with CTAs versus non-CTAs with the documentation saying why it should not warrant versus warranting. So then, you know, you can put what you're seeing based on your, but don't do like exact measurements, because when we see them, we're doing that measurements. We're documenting petechiae and the soft palate, you know, and those are things that we're doing with expertise to go and test it.
Right.
So you can document if you're seeing it, like just seeing it, but you don't have to like go in full details, because you can actually, when we come in, anyone, you can say, can we come in and see this with you at the same time? Because
Right.
what the avoidance is to have dual subpoenas to the court system for you guys.
Right. You want to document it in order to justify why you decide to order the CTA. So if you don't document it, then when it goes to court, they're not going to understand why. And that could come to question. But most of these documentation, when it comes to injuries, this is more relevant when it comes to a patient who's like in CCT, let's say, and like there's a wound that has to be repaired, things like that. In that particular case, you do want to document it before it's repaired, because unfortunately the forensic examiner will not get a chance to see those specific wounds in that case. But in all other cases, like Ms. Blair mentioned, you don't want to double document everything. You had a question?
Examining for like whether or not they we still document.
Right.
Exactly.
Your physical.
Your medical.
There's
Mhm.
two components, the non-injured patient and the injured patient. Every injured patient has to be evaluated by the physician prior to a forensic exam. So that exam is totally different. So when you do your exam thoroughly, and we done ours, the DAs are looking, okay, the doctor wrote, the patient came in with X, Y, and Z, warranted X-ray, warranted everything. When we get understand, we are collaborating with what you did, because we're finding exactly that same injury, now suture. That, you get what I'm saying? And then understand, we are asked, okay, because many times the defense is like, this patient came to the ER just to have a physical exam done. So our justification is no patient comes in with all these injuries to have a physical exam. So this is warranted and all based on the patient's initial complaint, why all these procedures was done prior to a forensic evaluation. And this is how we have literally worked the team to keep the medical providers from being subpoenaed in every case. So if you come in and a regular sexual assault with just no major issues to be sutured or anything, and start documenting signs of injuries, and it doesn't collaborate with what the examiner has in their sonogram or his sonogram, then they're gonna form you into to actually differentiate the difference that you're finding versus your finding. So it's basically a collaboration of documentation, one side is involved in it.
Exactly.
And it sounds like it's important to document remainder of physical exams,
You can-
refer to SART.
In the prior documentation, when we had paperwork, because we, you know, we started with literally, we had there was a slot that said, SART evaluation deferred, physical and genital deferred to SART evaluation. You know, because it's documented, because that documentation is there as proof as what is done. And remember, at the end of the exam, the attending physician is briefed on the findings of every case. I mean, the residents are involved, but the attending, it's a mandate from central office that every attending who signs off on a sexual assault case should be briefed off. You know, we know we work in busy times, sometimes the attending is not there, but at the end of the day, there has to be that communication in every case where your examiner is saying there was no significant findings, everything, you know, and we can discuss that. But it should never be double documented. If we find tears in the genital areas, Normally, the examiner will call back to the ED and ask the attending or ask them to send resident to see the tear so you can see if we need to elevate that to GYN at that time. Same thing with anal issues. We'll call so you can decide if you're calling in GI.
Right. So bite injuries is a perfect example of something that we have to be aware of. Like when we're examining these patients, if we do see a bite injury, that is medically relevant, right? So if a patient has a bite to the hands, we usually give them prophylactic meds. And so you have to, so of course, the forensic examiner is going to document that, but as well, we have to document there was an injury, and that's why we're ordering antibiotics for that. In addition to that, we'd have to ask the patient about Tdap. When was the last time they had, they got a Boostrix, and consider that as well. So when it comes to sexual assault in general, it's great that we have the sexual assault response team, which is created for the patients in order to help them when it comes to not only treating their sexual assault, but also collecting evidence and helping them go through the process of seeking justice. But most patients, when they present to the ED, they come to the ED seeking STI testing, prophylactic medications, and emergency contraceptives. For the most part, when it comes to vaginal intercourse, most patients have about 0.1% risk of contracting HIV through vaginal intercourse, and about less than 2% when it comes to rectal intercourse, and even lower when it comes to oral sex. However, this is what most patients are concerned about, even though hepatitis C is more likely if the individual is actually has hepatitis. It's almost always unknown what the HIV status of the assailant, but you have to keep in mind that if the individual does tell you that the person who did sexually assault them has a history of HIV, then you have to know that the patient can't get the typical PEP or PrEP in general. They would have to be seen by ID specialists in general. The other thing that most patients are concerned about is pregnancy. Even though it's only 2 to 6% when it comes to the risk of pregnancy when it comes to sexual assault, the last thing a patient wants is to have the fear over their head of whether or not they may end up with a child as a result of the sexual assault. So always consider that when a patient comes to the ED. So what are we treating when the patients come into the ED and we're giving them prophylactic meds? So when it comes to the things that we look for or we're treating for is trichomonas is one thing, and gonorrhea and chlamydia. As you know, there's been changes to the CDC recommendations when it comes to treatment of these particular STIs. Trichomonas, we're still giving metronidazole. Gonorrhea, we're giving ceftriaxone. It's a higher dose now compared to the past. In the past, we used to give 250. Now we're giving 500 milligrams IM. And if a patient weighs over 100 kilograms, then it's 1,000. It's 1,000 milligrams. So just keep that in mind. So it is weight-based over 100 kilograms. And then when it comes to chlamydia, we're not giving doxycycline instead of azithromycin for the most part. But there are some cases where we still give azithromycin. And of course, we also test for HIV and HBV to check their titers and also provide PEP for that as well. So one of the great things that Dr. Peacock worked on was creating an order set. I don't know if many of you are aware of this, but if you go to orders, there's panels and protocols, and under panels and protocols, you have SART. If you click on this particular SART panel, then it will not only auto-populate the testing that is needed for these patients, but also the medications. So it will also order the one-time dose of medication that they need in the ED, in addition to the packet of medication that they will be getting to go home with as well, if that makes sense. So if you click on this panel, then usually has just about everything that you need, except for antiemetics. So please order Zofran for these patients unless there's a contraindication for it, because they're getting a lot of medication. A lot of times they do experience nausea and sometimes vomiting if you don't order Zofran. Okay. So this is our flow chart, which is available on SharePoint, also on Clinical Monster. It sort of covers like all the steps I mentioned today, which includes activating SART, getting social work involved, the medications and the testing that we order for each patient. In addition to that, it also provides information on follow-up care. So patients can follow up with the ID clinic when it comes to sexual assault for males. And then when it comes to female patients, they can follow up with GYN in addition to ID as well. And when it comes to patients who are greater than 13 but less than 21, then they follow up with the adolescent clinic. And the red box here, I don't know if you can see it very well, but it states that we do give 7 days of prophylactic meds that is needed for the chlamydia, which is doxycycline. It is available in the Omnicell. So in addition to the HIV medications, the patient will also get a packet of doxycycline. Sometimes the nurses might not be familiar with it. So if they have any questions, ask them to talk to the charge nurse. And if the charge nurse is not able to assist them, then you can always feel free to call me as well. In general, I'm wrapping up and then I'm gonna hand it over to Ms. Blair. The absence of findings, like I mentioned before, 45% of patients can have forms of non-genital injuries when it comes to sexual assault, but the absence of findings does not mean that sexual assault did not occur. So this is extremely important when it comes to documentation. So if you do see something that is medically relevant, then you do want to document like the location, the size, and the appearance. Like Ms. Blair said, you do not want to double document. So the forensic examiner is going to be documenting in the forensic chart. But when it comes to strangulation or an injury that you're going to repair, you do want to document those specific things. Any subjective findings, tenderness on exam, and discomfort related to palpation. But you do not want to ever document normal exam. You do not want to say exam was normal. You do not want to say there's no evidence of sexual assault. There's no evidence of injury. We mentioned this earlier. This was brought up earlier during Leidy's presentation about alleged rape or sexual assault, or the diagnosis of alleged rape, or even the diagnosis of rule out sexual assault or rape. You do not want to ever document those things. And things to think about in general, patients who have acute trauma, they may respond in different ways. They may have problems recalling information. So please have patience with them. But in general, you don't want to ask detailed information. As Ms. Blair mentioned, the forensic examiner is going to come in and ask all of those questions. All you want to do is document what's medically relevant and ask questions when it comes to medical relevance. There's a lot of shame and stigma associated with it. We do not want to be a part of the problem. So please be very conscious of what you're saying, especially even if you're not near the patient may still hear what you're saying. So you have to be careful what you're saying because you definitely don't want to re-traumatize the patient in any form of way. And always mention, like I said before, you want to give the New York State victims, New York State Sexual Assault Victims Bill of Rights and the FRE form. But you also want to explain to them what it also states, which is like that we will provide them with STI testing and HIV medications and emergency contraceptives, because a lot of times that's what they're there for. And they don't know about all the additional stuff that we have to offer for them, okay? And if there's a case of strangulation, it's very important, extremely important, and it's the last thing that I'm going to say, that you medically clear the patient. If the patient has not gotten a CTA and they have any forms of findings that is consistent with our strangulation protocol and they haven't gotten a CTA, then they cannot move on to the crisis center for forensic examination, okay? So you have to reactivate SART once they're medically cleared and the CTA is completed. But you're always free to call SART before that point if you want advice on or if you have any questions.